will be presenting a case report on extraskeletal osteosarcoma. So to start off, the patient's chief complaint when coming into the clinic was a right knee mass. So to touch a little bit on her HPI, so she was or is a 35-year-old female, and she presented for a right anteromedial knee mass, and that pain was persistent for a little over a year. She described it as constant and moderate, but was still able to ambulate independently. So to give a little bit more background, really most of her background was unremarkable, except she did have an osteoid osteoma of the right tibia that was resected about 20 years ago, and no family history for bone tumors or any other relevant medical conditions. So on physical exam, and to put in perspective, I saw her post-op, but this was from her primary or initial visit with the attending that I was working with. So at her first presentation, she did have the right knee mass that was mobile yet firm. It was about 2 centimeters in diameter, and it was tender to palpation. All right, so some differential diagnoses. Since this is a very complicated bone tumor, we had a few different differentials. So looking into this, we had some soft tissue chondrosarcomas, which is a mesenchymal chondrosarcoma that can be found in young adults that produce calcifications. And then that's what we thought, like, this could be a differential. However, on imaging, you generally see what's called rings and arcs, which are calcification patterns that display the chondroid matrices, rather than what you find in osteosarcoma, which is more so like a cloud-like osteoid matrix. Comparing that to the giant cell tumors, which I feel like they love to, teach us and a lot in basic sciences, is that that's a rare malignant form of pigmented villonodular synovitis. And then this can present as aggressive mass, generally around joints. So that's why we had this on the differentials, because this patient, it was around the knee. So a possible diagnosis. Next, we had the myositis ossificans, or MO, and this is a benign reactive process of heterotopic bone formation that could present as a calcified soft tissue mass, which was a consideration. But generally, MO has zonal mineralization patterns on imaging with peripheral rim calcifications. And this has the lucent center, which tends to mature over weeks and is generally associated with trauma. However, this patient did not have any trauma in her history. Lastly is the synovial sarcoma. So this kind of tumor presents generally around the joints in young adults. So this does present and fit our presentation, but it shows calcifications on occasion. And on MRI, this tumor characteristically exhibits what's called the triple sign pattern on T2. So it's mixtures of high, intermediate, and low signals due to the solid, cystic, and fibrosis components found within the mass. And while our patient's lesion was near the joint, it didn't display the classic triple sign appearance. So for diagnostic tests, generally this is common with most to all bone tumors. First one is a knee x-ray. Then we moved on to MRI with and without con. And then lastly is biopsy. So with that, some results on I didn't include the x-ray because it was negative, but I wanted to focus more on the MRI results. So you can see here that we had the MRI with and without con, and it displayed a small superficial enhancing soft tissue nodule, which was medial to the right patella, which you can see, yes, right where the cursor is, in addition to some knee effusion around the mass. So on the left too, we had a hyperintense region, which is where Miranda's cursor was on T2, and that was enhanced post-con. On the right, we had the MRI that was sagittal cut, and that was hypotense, and it showed that dark little mass right there is about 1.5 centimeters, and that's on a T1 image. So going into some of the histology, we had the spindle cell neoplasm, which was composed of the spindle cells to epithelioid cells, and that had focal marked atypia, which was infiltrating the adipose tissue around the patella. Regarding the immunohistochemical staining, it was positive for the desmin, clusterin, but negative for keratin. And we did do gene sequencing on her to see, because it's a little odd, like having a history of osteoid osteoma and then now extraskeletal osteosarcoma, but we didn't identify any genes on that. So to give some statistics, ESOS makes up around 1% of all soft tissue sarcomas, and then 2 to 4 of all extraskeletal osteosarcomas. Now, what makes this case very unique is the superficial ECOS is extremely rare, and that contributes to less than 10% of all ECOS cases. And with this rare tumor, it's high-grade malignant mesenchymal soft tissue tumor, so you have a poor survival rate, and what we found in our literature search was 28 to 40%. There was some variability, but it is a very poor 5-year survival rate. And with that, you have to educate your patients on possible outcomes. But to also touch on why this case is unique, she was very young, having a bone tumor or an extraskeletal osteosarcoma at 35 years of age, it also being superficial, and then not having any bone or periosteal involvement is super interesting. And when we were writing up this case report, there was only 23 cases of superficial ECOS reported to date, which is mind-boggling in my head. But to go into a little bit of the management, and feel free to come off mute, type in the chat, whatever you want. What do you think was our plan of action for this patient after getting imaging, labs? Let's see, let's just disable. If anyone wants to come off mute, feel free. All right. So we did, I mean, if you want to click, because this one had one of the things, a radical resection and biopsy of the lesion was performed. And this was back in September of 2023. And also for perspective, I saw her in January, and then there was another student that saw her as of last month. But looking at some post-op imaging, here on the left, we had an MRI without con, and it's a transverse cut showing full resection of the tumor with no residual or recurrent tumor pieces in the medial aspect. And same on the right is sagittal cut with no residual tumor post-op. To give a little post-op update, as of 23 months, the patient is still in remission. She denies any residual knee pain, unexpected weight loss, or any changes to the knee. We just did a CT chest on her and it was negative. And what's most common is like it has metastasized to lungs in most patients. And that's when it's a downhill battle from there. So at this time, things are going well, and hope that they continue. But to go over, since I know step 1 and step 2 does and can test on bone tumors, I figured this would be a little review for everyone. So we're going to start on the left with less than 30-year-old patients. If anyone wants to participate and come off, feel free to think whatever you think this first one is on the top left, and we're just going to go down and then move to the right side. It's a little wonky looking, so I give you a hint. They always like to say the onion skinning pattern in those test questions.
Ewing sarcoma.
Awesome. Thank you, Vincent. And then down one on the right, what do we think that is?
Is that an osteoid osteoma?
Awesome. Yep. And then down one more. It always branches off and like looks really weird.
Osteochondroma.
Osteochondroma.
Yes, good job. and then sort of near the metaphyseal line.
Osteosarcoma?
I'm sorry, I didn't catch that one.
Osteosarcoma?
Yes, awesome. And then the one at the very bottom. It's
Mm.
benign and still has the periosteal reaction like the Ewing sarcoma.
Would that be a chondroblastoma?
Yes, that's good. I feel like that I never remember that one. That one's good. Okay, and to the right, so if you're over 30, I wanted to focus on two more common tumors that they like to test on. So what's the one up top that's covered?
Possibly chondrosarcoma?
Yeah. And it could also be a chondroma too, but yeah, the chondrosarcomas are generally in that area. And then lastly, the big one that I feel like they love to emphasize in school. What do we think that one is?
Giant.
Oh, sorry, I think I heard it.
Giant cell.
Yes, awesome. Thank you. Yeah, great job. I know, I feel like these are very, underrated, but they're easy points to get on exams. So if you at least like know the location, then you can narrow down most of them to the correct answer. But yeah, that's all. Thank you so much. Does anyone have any questions regarding this patient? Thank you, tumor.
With maintenance on her, is it an annual or biannual exam for this patient?
Yeah, I think for what the attending was wanting to do is like for the first 5 years, do annual screenings, and maybe after that go like every other year. But the recurrence rate is so high that he definitely wants to continue screening her every year.
Does this cause any issues with her like patellar function after the resection, or does she have any weakness or anything?
She didn't when I saw her back in January. She didn't have any complaints. It's honestly like if you're meeting her for the first time, you would have never known that she even had this procedure. She seemed not to say like normal, but in a sense like she had no complaints at that time. And then same when one of the other students I was working with on the paper, she saw her last month and she was still great.
Do they go through chemo as well?
Do they go through chemo?
Yeah.
Yeah, so you can't. So generally your options are like resection with or without chemo radiation. We didn't do that with her. But I think
Was
that's
there a
very
reason?
I was not there at that time of making those decisions. My guess would be that was due to her age and trying to see like if we could just resect it and not put her through that, since that, is terrible for quality of life and patient outcomes, stuff like that. But with the resection, she hasn't had any complaints. So I think that that was the right move to approach it that way.
In terms of quality of life, I was just thinking, what's the life expectancy of patients in general?
So within 5 years, most do die. Like the survival rates that I had found, which are slightly variable, but the uppermost was like 40%. It's generally like 20 to 40% survival rate within the first 5 years.
Oh. Okay. Thanks.
Yeah, of course.
It's more like open-ended, but was there anything else like compelling that you found with the other 20 some case reports describing this same pathology?
There were some where like the histo was slightly off in those findings, but I didn't see anything else that was like glaringly different other than the fact that they're superficial and that that's like extremely uncommon on top of it already being extraskeletal.
It was like attributed to like nothing. They just like theories like regarding the extraskeletal like findings.
Supposedly they're de novo, but we on her because it was weird, like she already had a bone tumor and then now going to a different type of bone tumor and us not finding any genes. I thought that was odd, but maybe they just weren't like, identified yet, and there
Yeah.
could be still something like new out there that they don't know. But I do find it very interesting that you could have one bone pathology and then, 20 years later have a very different one. And that's
Yeah, something totally unrelated,
much
right?
worse too.
Yeah. Yeah. Did anyone else have any questions?
Being that she did have the prior bone tumor and now have the osteosarcoma, just for my better understanding, would that be classified as a secondary osteosarcoma, or would it still be primary, being that they're like you just mentioned, they're two different kinds?
So I would classify it more as primary because the osteoid osteoma is a benign lesion. And they normally the osteosarcomas just are like I said, they come up like de novo, so there's no like real cause for it, unlike some where trauma can cause them to form. So that's why I would think more so primary versus secondary. I don't know if that answered your question well.
It did, thank you.
Any other final questions?